Okay, so I started my experience with rhizotomies about 20 years ago. And when I first started doing this, what do I know? So I just did my sedation like, you would do any other sedation, a little bit of propofol, a little bit of rapifin. And so when I started learning what this was actually about, I thought, well, this is really overkill, because we had to do these patients under general anesthesia because it was so painful. But now it's such a relatively small procedure, and to do a full anesthetic for that didn't seem for me to be right. So the procedure is actually non-invasive, although it can be very painful. And when you do a general anesthetic, of course, you have to manage your airway in patients who are prone. So you have to decide how you're going to manage this airway. And of course, an ET tube would be one way of doing this. And then you would need something like succinylthonium with all its possible risks to get the tube in. If you don't want to use sucks, you'll have to use a neuromuscular blocker, long-acting one. And of course, the procedures can be as short as 20 to 30 minutes. Now you have this long-acting drug on board. So if you don't want to put in an ET tube, you may consider an LMA. Now, I don't know about you, but I've never had the nerve to turn a patient prone and then put the LMA in, especially when they're lying on this very special theater table, which is actually designed in a very specific way to get these procedures done. And then when you think of it, if you have to turn your patient, because you start on the back and then you have to turn them prone, the LMA may move, so you may end up not having a secure airway at all. So all these things is just like, ugh, I don't feel comfortable with this. And then also, as you know, many patients with back pain are obese, and then you have to position these patients, you have to turn them and get them and position them on the table. So from my perspective, I thought that sedation should be good for these patients because it's less invasive than general anesthesia, and it then suits the minimally invasive procedure. You don't have to manage an airway. One of the best things that the patients actually can get onto the table by themselves. They can position themselves, and as Reggie said, it is not a comfortable theatre table. So you have to make sure that they are positioned properly, and because they're doing it themselves, you can skit hulle lekker in daarso until they are comfortable. And then if they are awake or under sedation, the surgeon can actually, as Reggie said, they can locate their pain by means of the patient response to where they put the needle. And then the patient response is also a monitor for possible neural damage. But then, when we started doing these things under sedation, I realized that you actually need quite deep sedation because it is very painful. So they can, as you know, slip into general anesthesia with respiratory depression and apnea. You can get airway obstruction. And then you're sitting with a patient asleep in the prone position with loss of airway, and now you have to manage your airway. So then you start thinking, oh, now you have to stop the procedure, you have to get the bed back into theatre, you have to turn the patient back onto their back again, and then you have to control your airway. So, this gets quite complicated. You may also have prolonged recovery after deep sedation, and then, of course, that negates the benefits of sedation if you have to do that. So it seemed that moderate or minimal sedation would be much more better for these procedures, and you have to control your pain, and you also have to maintain immobility because, as Reggie said, these patients can't move during the procedure because there's very specific position of the needle, and you can't have patients jerking around on the table. So I just realized that there has to be a better way to do this, and we have to find a different technique. So I was thinking, well, our first aim then should be to control the pain, because that is what is causing all our trouble, and we cannot rely on deep sedation to control the patient's pain. So in a way, we have to maximize the analgesia during these procedures. And if we can do that, then we can keep our patients responsive rather than putting them to sleep. If they're responsive and awake, we can maintain a patent airway, albeit maybe at the price of respiratory depression. And if the patient does get respiratory depression, because they're awake, you can talk to them and you can tell them, hey, come on, breathe a little bit, take a nice deep breath, if they may be getting a little bit deeper. And then this thing jumps by itself. Then, of course, you can also, as I've said before, the patient's response to when the surgeon puts the needle in is also monitor where the needle is, and if the patient is conscious, it's just so much easier to do that. So the patient can interact with the surgeon, and best of all, the patients can position themselves on the operating table. So just because I've been using alfentanil for a long time, I decided that we should probably go with alfentanil. Now, of course, alfentanil does have safety issues. There is the possibility of respiratory depression. And my biggest question was, will it give adequate pain relief? Well, we didn't know. And then you also know that there's always the possibility of muscle rigidity if you use too large doses. And that is really not something you want to have in an awake patient. And then we didn't know about the post-op events. If we're going to use higher doses of alfentanil, what will be the incidence of the nausea and vomiting afterwards? So we had to find an optimal effect site, target effect site alfentanil concentration that would give maximum pain relief with minimum side effects, and also ensured that the patient was still responsive during the procedure. So this is the article that I looked at. It was written in 1997 by Voek and colleagues, and they modeled different analgesics in combination with propofol, and then this was done for general anesthesia. So they looked at the best combination of the analgesics with propofol that will ensure the shortest wake-up time afterwards. So you must have adequate anesthesia, but the patient must wake up as quickly as possible afterwards. And of course they used the target-controlled infusions that by that time was just starting to coming out. So this is the results, and of course, because we were working or looking at alfentanil, we looked at this. So instead of going the general anesthesia way, we were looking at the time, or the concentrations actually, where the patients woke up. So these patients, or it was models, they modeled how these patients would go through the anesthesia, and then at what concentration of alfentanil and propofol the patients would wake up. So I thought, well, that may be good because we want our patients awake. So let's just see what the concentrations were when these patients woke up. And so they, according to their models, they estimated the plasma alfentanil concentration at awakening was around 64.6 and 73 nanograms per mole. And that was then, of course, in much higher propofol concentrations than we would use in sedation. So based on this study, we decided that we'll start with an alfentanil concentration of 70 nanograms per mole, and in combination with a very modest propofol concentration of about 200 nanograms per mole, or maybe you're more familiar with a 0.2 micrograms per mole that is on the TCI pump. So we were hoping that we would be able to ensure analgesia with some sedation, but without loss of consciousness. Now, we still didn't know whether this would take care of the patient's pain, because remember now they will be pretty much awake, so we will really need good pain relief. So we looked at some other studies, and Pavlin and Hill found that 40 nanograms per ml of analfentanil would give post-operative analgesia, and O'Connor found about 110 nanograms per ml would give good post-operative analgesia. Pavlin did a study in 1996 already, and they also combined propofol and alfentanil for sedation and analgesia, and they then also found that by combining the drugs you had better sedation and analgesia than using either drug alone. Of course, we know that these days. And they said there was some loss of alertness and increased sedation at a target propofol concentration of 150 nanograms with alfentanil of about 40 nanograms. And the other interesting thing was that they found that there was a plateau with the alfentanil synergism with propofol when the alfentanil reached a level of about 100 nanograms per mol. So I thought that was quite interesting too. So based on these studies, we thought that we will be able to ensure analgesia without loss of consciousness if we set our alfentanil concentration to about 70 nanograms per mol, and then the propofol at about 200 nanograms per mol, or 0.2 micrograms per mol. And then we have the option of increasing our alfentanil concentration up to 100 nanograms per mol as necessary. So we started doing this. Now, I must say, in the beginning, when we did the old-fashioned sedation, we looked at the patients beforehand and we said, oh, he looks a little bit anxious, so he'll get GA. This patient looks okay, this patient will get sedation. But now with this new technique, we just started to, just start this new technique, and I didn't tell the surgeons anything. We just started the new technique, and they were like, did you do something different today? And I said, why? No, well, everything's just going so smoothly. And then I just knew we had something here. So we just started doing all the patients in the same way with the alfentanil of 70 nanograms per ml, having the option of going upwards. So then we looked retrospectively at the data, and all patients remained conscious. Of course, there was a decrease in respiratory rate and an increase in CO2, as would be expected. There was no airway obstruction or airway loss. We had no airway intervention wasn't necessary, and we didn't have to reduce our rate of infusions. Okay, so about 30% of our patients were comfortable at alfentanil levels of 70 to 75%, and 95% of the patients were comfortable between 70 and 95%, 95 alfentanil concentration. So only 3 patients needed alfentanil of 100 nanograms per mol, and of those 3 were still not comfortable at 100 nanograms per mol. So you then, of course, have the option to up your propofol, even though you must then realize that those relatively high dosages of alfentanil, you may enter deep sedation if you're going to use more propofol. Of course, there are other possible problems that you can have. Patient variability, as I've said, some patients just take much less than others. Some patients are very anxious beforehand, so they are more difficult to handle. And just some patients just have more pain than others, so you just have to deal with whatever you get. And then there's also the question, so what do you do if it doesn't work? And then this thing about muscle rigidity is always in the back of your mind, that if you go too high, the patients may actually get this muscle rigidity. Okay, and then post-operatively, you may have other problems. Always the staff are less vigilant afterwards. Now you have these relatively large doses of alfentanil in the body, and may the patients actually drift back into sedation. And then there's also the late adverse effect of alfentanil that was described as a late recurrent respiratory depression, where patients who had alfentanil about 45 minutes after the infusion was stopped, they had respiratory depression, and that was on a wide range of doses. So it is very important to monitor your patients post-operatively. All our patients go to recovery, where they are kept until they are sure that they are okay. But I must say I've never seen this in the 20 years that I've been using this technique. So currently, for the average healthy patient, I would first start my propofol just because I want to limit the time that I use the alfentanil. And I usually start at about 0.5 micrograms per ml, just to kind of get them into the thing. And then they start cleaning and prepping the patient. And as soon as the surgeon puts on his gloves, I start the alfentanil at 70 nanograms per ml, because it works within 90 seconds. So you can really just start it right before we start. And then we see how it goes. And if the patient, you talk to the patient all the time. Are you okay? Are you feeling it? And as Reggie said, we do that chordal block first, which is really painful. And I must say, it is just wow to see him putting that needle there in the chordal. I don't know how many of you have done chordals on patients who are awake. It's really painful. So they're just lying there and say, are you sure you're okay? No, I'm fine, I'm fine. I must say, once in a while you get those, that was, it's not very nice, and then you just up your alfentanil until they are feeling better and they can handle the pain. Okay, so safety precautions, you have to titrate against the patient's response. Remember, the elderly and the sick and the frail patients, you have to adjust your dose. You cannot just go up. So with the elderly patients, I wouldn't start at 70 nanograms. I'll start my alfentanil maybe at 50 and then go up if it's necessary, or just check your patient. And if they're fine, you can go up. If they're not fine, you just keep it there and maybe give a little bit more of propofol. Check your patient responsiveness. So this isn't the time to read the newspaper, because they may drift into too deep sedation. And you can actually cause deep sedation if you're going to use these dosages. So you have to watch your patient. That's my story.